Hi, welcome to Physiology Open. In this video, we will see the pathophysiology of diabetes mellitus. To understand diabetes mellitus, you should know the functions of insulin on metabolism. In brief, we will discuss them in this video. For details, you can check out the video on functions of insulin, the link for which is given in the description section below. Diabetes mellitus occurs due to deficiency of insulin function, which may occur either due to decreased insulin release or due to decrease in its actions on its receptors, which we call as insulin resistance. Both decreased insulin release and insulin resistance obviously decrease the effect of insulin on various limbs of metabolism. So let's first see in brief the actions of insulin, which are mainly targeted to reduce the concentration of glucose, fatty acids, and amino acids in blood during the fed state when their concentration in blood rises. So for this, in liver, insulin promotes the conversion of glucose to glycogen, that is glycogenesis, and also to fats, that is lipogenesis. While insulin prevents the breakdown of glycogen to glucose, that is glycogenolysis, and synthesis of glucose, that is gluconeogenesis. It also prevents the beta oxidation of fatty acids. So fats are synthesized while their usage as fuel does not occur. In skeletal muscle, it promotes utilization of glucose and its conversion to glycogen. And in adipose tissue, it promotes storage of fats and inhibits lipolysis. In effect, utilization of glucose as energy is promoted and that of fats and amino acids is inhibited. Now, when there is deficiency of insulin, these actions of insulin are affected. So basically, storage and utilization of glucose decreases in fed state, leading to increase in blood glucose concentration after food, that is, postprandial hyperglycemia occurs. Not only that, due to continuing glycogenolysis and gluconeogenesis, glucose concentration in blood further increases. See, this action in liver, that is glycogenolysis and gluconeogenesis, continues in between meals too. That's why continuously glucose is released into blood. So even fasting blood glucose concentration is high. Now normally blood glucose filters in nephron. But at normal blood glucose concentration, that is about 100 mg per 100 ml of blood, all the filtered glucose is reabsorbed into the blood. However, in state of insulin deficiency, due to excess blood glucose concentration, the filtered glucose is also high. This exceeds the capacity of nephron of reabsorbing the glucose, that is, transport maximum is reached, above which the nephrons are not able to reabsorb further glucose, and hence glucose starts appearing in urine, that is, glucosuria occurs. The presence of glucose in nephron acts as an osmotic pull for water, preventing the reabsorption of water also from the nephron. So water loss increases, causing increase in the volume of urine, that is polyuria. Due to increase in water loss from the body and hyperosmolarity of blood, due to increased blood glucose concentration, water starts moving out of cells. Now this, when happens in osmoreceptors, thirst centers are activated, causing increase in the intake of water, that is polydipsia. So till now, we discussed physiological basis of certain signs and symptoms of diabetes mellitus, that is fasting and postprandial hyperglycemia, glucosuria, polyuria and polydipsia. Okay, let's move further now. We know there also occurs polyphagia in diabetes, that is excessive eating in diabetes mellitus occurs. Why? Well, hypothalamus has two centers which regulate feeding behavior, satiety center and feeding center. The neurons of satiety center are glucose sensitive and are dependent on insulin for the utilization of glucose. Yeah, this is an exception because neurons do not depend on insulin for glucose utilization. So normally when the blood glucose concentration is high, as in postprandial state, satiety center neurons are active and inhibit feeding center, causing decrease in feeding. However, same does not happen in diabetes because when insulin is deficient, the satiety center neurons are not able to utilize glucose and become inactive. Thus, they do not inhibit feeding center. Since feeding center is not inhibited, the person feels hungry and eats often. That is, polyphagia occurs. One thing you remember that despite eating more, the body is not able to utilize the glucose as fuel. That's why diabetes is basically a kind of starvation occurring despite presence of lots of fuel. That is, in the midst of plenty. Anyways, so what happens when body is not utilizing glucose, other fuels are brought in. Remember that insulin spares the use of other fuels in fed state, right? So in insulin deficiency, lipolysis starts in adipose tissue, causing release of free fatty acids in circulation. Thus in diabetes, blood-free fatty acid concentration increases. Proteolysis also starts. So with increased lipolysis and proteolysis, there is weight loss. The free fatty acids enter liver and undergo beta oxidation, leading ultimately to formation of acetyl coenzyme A. This formed acetyl coenzyme A has two fates. One, either it enters into Krebs cycle and is oxidized to carbon dioxide, or second, it enters a ketogenesis pathway leading to formation of ketone bodies. When more and more lipolysis occurs, as occurs in insulin deficient state, more and more acetyl coenzyme A is formed and hence more ketone bodies are formed. Moreover, in diabetes, most of the acetyl-CoA is channeled away from Krebs cycle and is utilized for production of ketone bodies. Some of the ketone bodies are utilized as fuel. However, when insulin levels are very low or virtually absent, as seen in type 1 diabetes mellitus, rate of production of ketone bodies is so high compared to their rate of utilization that it decreases blood pH, since ketone bodies are acidic. Thus, it causes metabolic acidosis, also known as ketoacidosis, since ketone bodies are a cause of this metabolic acidosis, right? These ketone bodies are also excreted in urine, that is, ketonuria occurs. Now, since blood pH decreases, body starts compensatory mechanisms for excretion of excess acids by increasing respiratory rate and depth. This is known as Kussmaul's breathing or air hunger because respiration is very rapid, deep and labored as if the person is hungry for air. Some ketone bodies, that is acetone, is also excreted by breath, causing fruity smell of breath. Now, this ketoacidosis is always accompanied by dehydration. See, we have seen previously how diabetes is causing loss of lot of body water. Generally, ketoacidosis occurs when insulin levels are very low. In these cases, blood glucose concentration is too high, causing too much glucosuria and hence polyuria. So, due to dehydration, body starts compensatory mechanisms for restoring blood volume. See, hypovolemia leads to decreased renal blood flow and hence GFR, causing increased tubuloglomerular feedback and hence activation of renin-angiotensin-aldosterone system, thus causing hyperaldosteronism. Since function of aldosterone is absorption of sodium and excretion of potassium, it leads to increased potassium loss from the body. Now here is a paradox that despite potassium loss from the body, if we check plasma potassium concentration, that may appear to be normal. Why? Because when acidosis occurs, what happens is hydrogen ions start entering the cells, and this is accompanied by movement of potassium out of the cells, thus giving false information about plasma potassium levels. So that was about ketoacidosis. Now in type 2 diabetes mellitus, ketoacidosis is not that common since insulin receptor defect starts slowly, that is, some actions of insulin are preserved. So lipolysis and proteolysis are not that severe. Thus weight loss is also not that severe. Also, since lipolysis is not that much, formation of ketone bodies is also less. In contrast, another problem may occur in type 2 diabetes, that is hyperglycemic hyperosmolar state. In this also there is hyperglycemia causing high serum osmolarity. This causes glucosuria and polyuria and hence depletion of water. However, ketoacidosis is not present. So in summary, the clinical features of diabetes are hyperglycemia, both fasting and postprandial, glucosuria, polyuria, polydipsia, polyphagia, then rise in free fatty acids concentration in blood, weight loss in type 1 diabetes mellitus, while in type 2 diabetes mellitus, there may be normal weight or even weight may be increased since that is a cause of insulin resistance. Now, in extreme conditions, ketoacidosis can occur with Kussmaul's breathing, or hyperglycemic hyperosmolar state can occur, then type 2 diabetes mellitus, then dehydration and depletion of potassium. Okay, thanks for watching the video. If you liked it, don't forget to press the subscribe and share button. Thank you.